So thank you, Elizabeth. So I'm going to repeat for those who couldn't hear. So what Elizabeth has is a disease called stiff person syndrome. It's also a rare immune-mediated disorder in which certain antibodies actually affect the brain. And what she suffers is whenever she hears certain loud noises, she starts to experience involuntary movements. The muscles get stiff. She has difficulty thinking, difficulty walking, and also pain. So let me ask you, why is that happening? Why somebody that when you hear a loud noise, an ambulance, we normally don't experience that. So why is that happening? And that has to do with the number one function of the brain and the central nervous system. And every time I ask this question to the students, every time they get it wrong, which is, what is the number one function from a sensory input to the brain? And the number one function is to stop sensory input to the brain. Think about this for a minute. So now today, in this precise moment, your brain is getting a lot of information. You're getting visual information. You're seeing the screen. You're getting temperature information, how cold the room is. You're getting tactile information, how is the clothing affecting you. You're getting auditory stimulation, trying to understand my accent. What is this guy talking about? So you're getting all of this information. You just ate. So you're getting some sort of postprandial information to the brain, something we call interoception, the internal organs telling the brain something. So the number one function of the brain is to select what information is going to become meaningful, so you pay attention to that. And you channel that attention to something that you feel is important. Hopefully now you're challenging auditory and visual information because you want to learn something out of that. And you're probably ignoring how the clothing is affecting your skin because you don't feel that's important. So that's the number one function of the brain, to try to select of all the information that comes to the brain, whether it's external or internal, and try to understand which one I need to pay attention to. And the brain does that in a beautiful way. It's a perfect balance, something that we learn since we were kids, to try to understand when I walk, I need to start thinking first how to move the legs, and that's why the kids walk in a wobbly base. But then as you learn that, you stop thinking about it. When you first learn how to ride a bicycle, you have to think about a lot of things, and that becomes kind of like a voluntary type of process. The moment you learn that, you shift your attention to other things. Instead of thinking about how to bike, that became automatic, and then you think about something else. So the brain is very plastic. So what happens is that we are constantly feeling pain. Everything that actually touches us could be perceived as painful. But we learn to stop feeling that as painful and to move on. So humans, we are not designed to wear shoes. But we do that because it's part of our culture. So the first time we wear shoes, we were kids, we don't remember, but probably that was painful. But then you get used to that. Your brain gets used to that, and that sensory information does not become painful anymore. So what happens when you disrupt that homeostasis, when you change that balance in the brain or in the central nervous system with something, whether it's an antibody causing stiff person syndrome, whether it's a vaccine causing transverse myelitis or post-vaccinal transverse myelitis, whether it's another antibody causing NMO. Well, all of a sudden, you disrupt that balance. And things that before were not painful, now the brain perceives that as painful. So that's one of the types of pain that actually we see in these disorders, which is called the central pain. And it's one of the most challenging pains to treat. Because one of the things you have to do is rebalance the homeostasis of the brain. So things that are now perceived as painful, we get distracted and we don't think about them. And that's the basis for some of the therapies that we actually find them useful, which has to do with neurofeedback, biofeedback, try to modulate brain responses in ways that we get distracted from thinking about this in a voluntary way to now become automated. Okay? So I thought that Elizabeth's story is perfect because her story is similar. So why now loud noises become a trigger for involuntary movement? It's because you are disrupting the sensory input and the output of the brain. So pain is individual, is learned, and is a social response. Another example that I have from this is when I trained couple of 8 years ago now, I was in Boston. I was doing a fellowship in neuroimmunology, and we were two fellows. The other fellow was from Denmark, and the first time she saw me doing a spinal tap, I prepared the patient, and I gave the patient local anesthetics with lidocaine, and she asked me, "Why are you doing that?" I said, "Well, so the patient doesn't feel pain." Well, in Denmark, we don't use local anesthesia. Like, do you use any pain medications? No, absolutely not. And patients don't complain. And she said, well, because we are Vikings in Denmark, and we have a different pain tolerance. And there is something to be said about culture. And you see that different cultures have different pain thresholds and different tolerance. And it's something that actually we learn. So it depends. And that's why when you look at pain studies, you have to take that into account. Who were the patients and what type of pain you're talking about, and how did you measure the pain? So this actually explains, I was planning on showing you the anatomic basis of what I just explained, but I think Elizabeth's story clearly exemplifies what is the pathways. So basically we have receptors of pain. They are everywhere. They are externally located. They are internally located. And then you have to have some sort of transmission from that receptor all the way to the brain. And the problem in pain could be in the skin, in the receptor, in the transmission, in the cable, in the wire, or could be in the brain. And if you make an analogy between the nervous system and the electrical wiring in a house, you can have a problem in the outlet in the kitchen, you can have a problem in the wires going through the walls, or you can have a problem in the electric panel. And try to diagnose where the problem is in pain is going to help you address the pain syndrome accordingly. So when the problem is in the central electric panel, we call it central neuropathic pain, something in the brain, something internal that is actually not helping us modulate pain receptors or pain signals. So this is just to show you two real cases, examples of patients that has transverse myelitis. As you can see in the first slide here, there is a large lesion, and you can see this large white clear signal in the middle of the spinal cord. And that's a patient with a longitudinal extensive transverse myelitis with Neuromyelitis Optica. And then you can see a second patient here with a tiny little lesion here. It's a single level lesion from multiple sclerosis. Well, let me tell you that this patient feels that the pain is uncontrollable and suffers from a terrible amount of pain that interferes with his quality of life, whereas this patient has zero pain. So one of the difficulties with pain is that what we see on the MRIs may or may not correlate with the amount of pain a patient actually suffers for a variety of reasons. So let's talk about some, any questions? Okay, let's talk about some language here. So we can divide pain or determine the quality of pain in many ways. One is on duration. So acute pain is what we refer as the pain that actually lasts less than 6 months. And usually whatever the cause of the pain is, when we address that, the pain will subside after that. Chronic pain is the most common type of pain in these disorders. It's a very complex process. It's multifactorial, and the duration is over 6 months, and for the most part is chronic lifetime pain. How frequent is pain? Well, the published literature is telling us some numbers, but the reality tells us that it's more. So for the most part, pain is under-recognized and underdiagnosed. And that's for a variety of reasons. But at least what we know in published literature is that up to 50% of patients with transverse myelitis will experience pain at some point in their lives. A quarter of patients with Neuromyelitis Optica. The range is big, 30 to 86% of patients with multiple sclerosis, with spinal cord disease. And the reasons why we have this broad representation of pain in terms of the prevalence has to do with these factors, that what for somebody is an extremely painful experience, some other person may not recognize as painful. So pain is one of those areas that we actually have to practice patient-centered medicine. It's important to know what happens to 1,000 people, but we need to concentrate on what is happening to you today in this precise moment, because everybody's experience is different. So there's been 9 different categories of pain described in multiple sclerosis patients with spinal cord disease, and that's why I thought to include that in today's talk, because it's the area that pain has been more extensively studied. And those are the 9 different categories of pain. So we talked about the first one, which is central neuropathic pain, the problem in the electric panel. But then there are certain nerves, cranial nerves or nerves in the periphery that actually can, in isolation, cause pain. Something very common in MS, it's not that common in transverse myelitis, is something called trigeminal neuralgia, which is pain in the face. And patients describe it as cluster of short events of electrical sensations going on the face at any point, at any time, that they can have up to 20 events per day, highly disabling pain events that actually last from 10 to 20 days, and they resolve spontaneously. The nucleus of the trigeminal nerve, where the neurons live, goes all the way from the brainstem to the cervical spine. So in occasions we find that patients with transverse myelitis, they can also have trigeminal neuralgia. There is something that actually most patients with some sort of inflammatory lesion on the spine, particularly in the cervical spine, tell us. That is something called the Lhermitte's phenomenon. Anybody's familiar with that term? Okay, a few people. So what that is lesions on the spine often will cause inflammation around that when patients flex the neck down, that triggers some sort of electrical sensation shooting down the spine. It's like you're touching a wire, and that actually gives this odd sensation of pain that goes all the way down, particularly when you move your neck. The typical presentation will be flexing the neck forward. And that's something called the Lhermitte's phenomenon, and it's another of those type of pain syndromes in the spinal cord. Then pain can come from the cord in causing spasms, which are these episodic spasms. They are different to the spasms coming from the muscles or the spasticity that they talk today and we can talk later, which is this very brief, paroxysmal, sudden onset, involuntary contraction of the limbs, like that patients may have multiple times a minute, multiple times a day, that become painful, but is triggered by the spine as opposed to the muscles. And then we have the spasticity-related pain. So as we discussed before, if the muscles get stiff because the signal from the brain gets interrupted, the muscles naturally will try to contract. And that over time triggers pain in the muscles. And that's a different type of pain than the painful tonic spasms. Some individuals, particularly with Neuromyelitis Optica, may experience optic neuritis or inflammation in the optic nerve. And in addition to having decreased visual acuity, they may experience pain. And that pain is usually in the eye or behind the eye. When the patients move the eye, it feels painful. Sometimes it's confused by migraine headaches or ocular migraine headaches early on. Another type of pain is a musculoskeletal pain that may or may not be associated with spasticity, which not only the muscles hurt, but actually the joints hurt. And imagine this for a minute. You have in your knee, you have a group of muscles that actually are pulling down and a group of muscles that are pulling up. And if you put those two muscles with spasticity, the knee is going to hurt. And that's why patients over time, they tell you that they start with muscle pain, they feel stiff, but now the joints feel painful and the hips are painful. And particularly those large, high weight wearing joints that start to hurt. And that's a different type of pain. Of course, headaches are common, and up to 80% of patients with MS at some point in their life will have headaches, and there are many types of headaches. And last but not least, sometimes with our treatments, we can induce pain in our patients. So one of the first things we have to do is review the medication list and make sure that we are actually not causing pain with our treatments. So what happens if we ignore pain? Well, you can see the list here. It's the number one reason why patients suffer from their quality of life. It can result in decreased appetite, weight loss, disturbed sleep, fatigue. Anastasia is going to talk to us in a few minutes about fatigue. One of the first things we ask in somebody with fatigue is how do you sleep and why you don't sleep well. And usually pain is one of those reasons. It can actually affect your behaviors. Depression, anxiety, aggression, intolerance, those sort of things that actually usually come as a consequence of a poor pain management. So in the next 15 minutes, what I'll do with you is review medications. And I know that one of the most popular questions I always get asked is the use of marijuana. So proactively, I decided to actually talk to you about marijuana. So hopefully I can address that question. And also in the use of narcotics or opiates, which is another question that I understand when patients get to a point in which pain is so uncontrollable. That's a shortcut to some sort of benefit, and there could be some sort of misalignment with how providers perceive that importance. So I thought to proactively cover both topics. So a couple of years ago, I was asked by the American Academy of Neurology to create a work group to address the evidence that is published in the literature in looking at pain management in MS, because it's all over the place. So we put together a group and we looked at everything that was published and tried to correlate that information with the evidence category and see whether that's something that we should create some sort of best practice approach. So just to show you, and this is a small font, I don't expect you to read any of this, but just to show you how the exercise went. So we will review each article separately. We'll look at the descriptions, the outcomes, how the article was designed, and what are the results of that article. And we did that with everything that was actually published on pain management in multiple sclerosis. And we came to this conclusion that there were some medications that had some evidence of efficacy in the management of central pain in MS. And you can see that medications like gabapentin, pregabalin or Lyrica, trileptal or Tegretol, those are anti-epileptic medications. They were found to be efficacious in the management of central pain, but as you can see, the recommendation level was U, which data is inadequate. And that's usually a result of the fact that the studies were not well randomized or the design was not power enough to be able to make conclusions to the general population. So even though there is some hints of efficacy, the actual strength of the data was not good enough to be able to be categorized as established or well-established recommendation. You can also see that we did pay attention to the cannabinoids over here, and we look at the studies that looked at the use of certain cannabinoids products in the treatment of pain. And not to dive too deep into this, but actually, as you know, marijuana has two components, the THC and the CBD components. So those are two chemical components of marijuana. And depending on what is the balance between the two, you get more of a high effect of the psychoactive properties of marijuana, or you get more of the relaxation effect from the properties of marijuana. So basically THC is the compound of marijuana that is going to make people high. And it can cause anxiety, palpitations, vivid dreams. That's the psychoactive part of marijuana. Where CBD is the second compound of marijuana that is the opposite. It's going to cause muscle relaxation, decrease anxiety, antipsychotic properties. So when you hear stories that somebody used marijuana for recreational purposes and they had a bad trip or they have some sort of hallucinations or psychosis, probably is because they were getting a product that had more THC and less CBD. Okay? So when you look at medicinal use of marijuana, for the most part, these studies were done with products that actually has no THC and it's only CBD, meaning products that are not going to cause any type of psychoactive response, no dependence, no addiction to it. Okay? one of the challenges that we have in medicine with marijuana now is that one thing is what we learn in studies in which you know what product you're using. There is some sort of control in understanding I'm using this compound with this amount of CBD versus THC or no THC whatsoever, and I'm getting this effect. But then if you try to recommend that to a population in which then you're going to go to a dispensary and who knows what you get, you may or may not get the same response. So I do think that we need to learn more from marijuana. I think it's worthwhile actually continue to invest in studies to understand how to use it. But if we are going to treat it like a medication, that we should probably, also we need to understand how to prescribe that and what are the products that actually are going to be similar to have some sort of bioequivalence to the products that were used in the studies. Okay? So with that in mind, the studies using marijuana in the oral mucosal spray or the oral cannabinoid, which is CBD only, they were found to be effective in one study, which is the first one here, in decreasing central pain with a recommendation level of B. In the exact same outcome in a different study was found to be ineffective with an evidence of A because it was a well-randomized study, and it was the exact same outcome. And then other two studies were shown to be one ineffective and one effective with a possibly efficacy recommended level. So hopefully you get a sense that the studies are all over the place, the results. Part of that is because it's hard to define what exact product you're using and also the outcome that you want to accomplish. For example, which is not included in this list, the use of CBD in spasticity, in muscle spasticity in patients with MS was found to be beneficial in improving the quality of life of patients with spasticity. But when you actually measure how stiff those muscles are, it did not change the scales. So basically, it's possible that the effect in those patients were just making patients feel better, which you may argue that by itself is a good outcome, but we need to understand what are the consequences of that. But the actual effect on spasticity did not change the scale. So I'm hoping to address any questions on marijuana because I know this is a hot topic, understandably so, but I think we have some questions here. I'm not aware of any study on children. Terry, do you know any studies on children?
So there's been a lot of case reports about the use of CBD oil with children, but I think only now are we doing normalized sort of studies looking forward at how these medicines impact seizure frequency.
Good. Any other questions on marijuana? Good. And then opiates. So I thought that for this, I want to remind ourselves and the audience on what is the statement, the position statement of the American Academy of Neurology. And we function under their legal restrictions. And what they did is they came with a position statement a couple of years ago that recommends physicians, neurologists, that the use of narcotics should be minimized to certain situations. And if a patient requires more than 80 to 120 milligrams daily of morphine or morphine equivalent, then we should refer those patients to a pain clinic. And the reason for that is because, as you can read here, over 100,000 people died for the use of prescription opioids since the policy changes in the 90s. And the concerns is that the unrestricted use of these medications without true guidelines, it could lead to more side effects and consequences than the potential benefits. For the most part, we try not to use narcotics for chronic pain syndromes. There are a few exceptions in which the quality of life in end-of-life care may allow us to actually do that in patients with terminal cancer or ALS. But for the most part, we try not to, and in the case we have to, there are certain guidelines that we have to follow, including we need to create a contract with a patient understanding what are the expectations and what are the certain limitations that we have in terms of the use of narcotics. Okay, so any questions? Good. And now the fun part of pain, and the reason I say that is because it's not that I'm opposed to medications, but actually I'm an advocate for integrating non-pharmacological approaches to pharmacological approaches. So understanding that pain is so complex and there are so many reasons why people can have pain, hopefully gives you a sense that a pill is not going to do it alone. So there are more than just a medication to addressing pain. And that's when the non-pharmacological approaches play a very important role. And in terms of medications, those are general concepts that we do try to follow. We usually start with a low dose and gradually titrate that up to reaching the level of efficacy. If partial but not complete pain relief occurs with one medication, a combination of two or more medication is preferred over going to toxic levels of one medication. And if you choose a different medication, go to a different mechanism of action. So if the first drug that you chose is an anti-epileptic drug, maybe choose an antidepressant. So you have higher chances of combining mechanism of actions to create a synergistic response to pain. And when you are pain-free, and then how long you stay on the medications? Well, if you've been pain-free for 3 to 6 months, it's reasonable to maybe titrate that down and see whether you truly need to be on such a high dose of anti-pain medications for life. That's one of the things that as physicians we always fail to do, which is we somehow know how to start a medication, we don't know how to stop it. And I think those conversations should happen constantly every time you see your physician. So physical therapy, you had an entire session with an expert today on the importance of physical therapy, so I will just simply want to reiterate the importance of active movement. Not only it helps with brain plasticity as well, but helps to rewire all these pathways that we were talking before that somehow are altered with this condition. Non-surgical treatments like electrical stimulation or transcutaneous electrical stimulation is a modality that we try to use. Acupuncture, of course, and exercise. And then you have surgical treatments for pain in which you have neuroblockade, surgical lesions, in which what you're doing is, going back to the example of the house, you have the outlet in the kitchen, you have the wire, and you have the central panel. If you could not figure out where the problem is, you cut the wire, okay? And that's what surgical treatment is, hoping that the brain or the spinal cord will rewire itself, and hopefully that function that the wire was bringing will be taken over by somebody else or some other system, okay? So this is an extreme situation, depending whether you do the neuroblockade, that's something transient and reversible, whether you do the surgical lesion, that's an irreversible, that depends on your situation and the conversation with your surgeon. Then, you have things like hypnosis, psychoeducation, and behavioral treatments. Even though I found this funny picture, we shouldn't take this lightly. Actually, these are modalities that are very helpful, and for the most part, they are safe. Access to these may be an issue depending on your insurance, but actually behavioral treatments, and I just had an entire slide on that, is because they're known to cause significant improvement, relaxation, biofeedback, neurofeedback, cognitive behavioral therapies. Basically what you're doing is making autonomic responses voluntary and try to rewire and focus your attention from things that actually are concentrating on pain into something else. So biofeedback is a modality that is very helpful in many pain syndromes, including migraine headaches. So it's something that if you haven't done and you suffer from pain, you may want to consider. And then it was alluded before in the talk, the spasticity. I will go through this very quickly because it was covered. You have many options to treat spasticity, including baclofen medications, baclofen pump, and the use of Botox. So all of those options actually you should have in mind when you talk to your provider about pain. And just to summarize at the end, pain syndromes are common and for the most part under-recognized. Pain syndromes are usually associated with other things. They are complex. It's not just one problem. And trying to understand the cause of the pain early on will help you better. So don't wait until the pain is too disabling in your life to ask for help. If you feel that pain is becoming an issue, talk to your provider early on, because it's going to be probably simpler at that point to understand what is causing pain than if you wait until pain becomes a bigger problem. And as we mentioned before, there are pharmacological and non-pharmacological interventions that you can do. And as usual in these complex syndromes, a multidisciplinary approach with multiple things together usually is better than just a single medication. So with that, I would like to end and be open to any questions you may have. Yeah, so the question is does anybody becomes pain-free? Absolutely, yes. So it depends, of course, on the cause of pain. But yes, so pain could be transient. Pain could be just simply a matter of understanding the muscles, the musculoskeletal component of that. And with the right physical therapy exercise program, you could. Even early on in neuropathic pain with certain medications and lifestyle modifications, you can certainly expect being pain-free. So the answer is yes. Yes, that's a great question. So along the lines of the underreported problem of pain, particularly in kids, in populations that may be more difficult to diagnose pain, is there any other tools that we can use? And you're asking the right question at the right time, because now is the time in which we are finally moving towards what is called the patient-reported outcomes, or PROs. And those are outcomes that are based on self-reported questionnaires that we can implement in patients. And this is shifting again from the doctor-centric approach to the patient-centric approach, in which before we used to just look at somebody and say, I think you are depressed, and then diagnose depression that way. Now we are taking our time to actually bother to ask the patient, are you depressed? And so we have all these questionnaires that might help us actually make those diagnoses. So pain falls into the same category. So we have a battery of questionnaires that actually we can ask patients to fill. Some of those are age-appropriate questionnaires. Some of those are not. Terry, probably you can fill in the question, but sometimes you diagnose pain indirectly through behavioral problems in school, right? Or irritability, or the kids didn't want to go to physical activity, or they were fighting. So pain could be masked by all of these compensatory behaviors.
Yeah, I actually don't have bad pain. I describe it as being uncomfortable. But the best success I've had is with over-the-counter topical things like BioFreeze and Aspirin seems to do the trick for me. Any dead thing or that you can pose on through on. Also, if it gets really bad on the side, I'll get one of those spandex t-shirts, and for some reason that works like a drug. It takes it away like that.
Yep.
This over-the-counter Aspirin really does a good job.
Exactly, and just to reemphasize what you were just talking about, what you're doing is one of these therapies that I have listed here, which is cutaneous stimulation, right? So it's the first bullet. So topical sometimes help from the pharmacological component of that, but sometimes just help by massaging the area, by just going through the exercise of doing that by itself. Even if what you put is olive oil, it's going to help you, okay? So it's sometimes more complex than what we think it is. So if you feel that that's helping you, that's fantastic. You just found your treatment. And for the most part, you shouldn't complicate that beyond that. So keep these non-surgical and non-pharmacological approaches there. Actually, they could be beneficial.
off and now there's scar tissue there. I guess I have a hard time understanding how a topical cream affects that pain.
The question has to do with if the pain is central, how can a topical cream will affect that? And the answer is probably we won't. And that's why I hopefully explained to you there are 9 different categories of pain. And if the one that you have is actually central, again, we are talking about going back to the house, the outlet, the wire, the electrical panel. If the problem is in the electrical panel, no matter what you do in the outlet, it won't help. So the first step to treatment of pain is understanding what is causing the pain. Exactly. So for central, so for central pain, so all of these medications that I reviewed with them, they were studied in central pain, which is one of the most challenging types of pain to treat because you have to get to this electrical panel, right? So for that, you need medications that go either straight to the brain. That's the concept in spasticity, for example, with the baclofen pumps, and some people use morphine in pumps. Or you have to use medications that are central acting. And those are the examples of gabapentin, Lyrica, or pregabalin. So in central pain, topical medications probably won't help. Mm-hmm.
My pain doctor told me to ask, what's the latest thoughts about using spinal cord stimulators? He's trying to push one on me, and I'm really resisting it.
Yeah. So there are many types of stimulators. I think the evidence is poor. At least I'm not aware of any significant evidence. And it has to do with the second bullet here, which is this concept of electrical stimulation. It might help better for musculoskeletal type pains. For central pain, I don't have any evidence that actually helps. That scares me, but I don't have any evidence. Anyway, so thank you for your attention. One more question. Yes. So the question has. Great. So the question has to do with Ampera. And Ampera is a medication that is FDA approved for walking impairment in patients with multiple sclerosis. The mechanism of action of Ampera is by working around some channels, the potassium channels, that actually what it does is change the electrical transmission in the brain, in the nerves inside and outside the brain, making the nerves more ready to work. So wake up the nerves, okay? And that's why if you have areas of demyelination along those nerves, the function that those nerves will transmit, it might improve. So the medication was found to improve by 25 to 30% the speed of ambulation in patients with MS. Paradoxically, we found that actually pain syndromes tend to get worse, particularly central acting pain syndromes. Because again, you could be enhancing that pain transmission along the nerves. So for pain, I haven't used that. But for ambulation, if a patient is weak, and because he or she is weak, can't move, and because of that develop spasticity, and because of that develop pain, sometimes breaking the cycle, but making patients walk better, they exercise more, and the spasticity gets better. So indirectly it might help for some pains, but for the neuropathic pain, actually might make the pain worse. Thank you for your attention.